Good morning, good evening, wherever you're logging on from. Welcome to the August version of the Australasian Pleural Seminars. Today we are very honored to have Dr. Eihab Bedawi, who is a respiratory physician and pleural specialist in Oxford, England, getting up very early in his time to come and talk to us about pleural procedures. Now, we all have seen pleural procedures going wrong, and I think we all agree that training and safety is important. But how to go about doing it is the difficult part. Now, Eihab chaired the recent ERS pleural infection guidelines, and he was also heavily involved in the BTS pleural procedure clinical statement. So he's the best person to come and talk about how to make pleural procedures safer, smarter, and better in 2025. So just remind the audience that if you've got any questions, please just put it on the chat while we go along, and we'll read it out and at the end. So without further ado, I'll hand the floor to Eihab. Thank you very much for joining us.
Thank you very much. Good morning and good afternoon, everyone. Thank you for the very generous introduction, Gary. It's an absolute honor and a privilege to be presenting at the Australasian Pleural Seminars. So what I'm going to be covering today is introducing to some of you who may have not come across yet the BTS Pleural Procedures Clinical Statement, which was created and published as a supplement really to the main guideline, but is really a really rich resource in itself, and may have not grabbed as much attention as the main guideline, and I'll sort of be talking about that. I'm going to be talking about a recent national review of pleural procedure incidents that we carried out in the UK. I'm going to be introducing the concept of LOCSIPs. Many of you may be already familiar with these, but I think they have recently come back to light again. We're going to be talking a little bit about patient safety, anticoagulation, and how to make our procedures better. So many of you will remember these guidelines. These are well established. These are the 2010 local anesthetic thoracoscopy pleural disease guidelines in 2010, and then the pleural procedure and thoracic ultrasound. And these obviously came on the back of the very famous National Patient Safety Alert, the NPSA, in 2008, and they mainly covered pleural aspirations and Seldinger chest drain insertion, as there was very clear evidence of harm occurring from these two procedures. The main highlight was introducing the concept of ultrasound guidance, which was still then a sort of a very sort of trendy thing that people sort of talked about, but no one really did. So these really started to encourage, let's say, or really recommend the use of ultrasound in pleural procedures. But now, this is the 2023 BTS clinical statement on pleural procedures. And the reason I think this was necessary was because now pleural intervention and pleural procedures are far ranging beyond simple aspiration and chest drain insertions. So what this statement wanted to cover was safety and preparation for pleural procedures, pleural aspiration, intercostal drains, but also look at IPC insertion, management and removal, which have really revolutionized management of malignant pleural disease in the last decade or so, ultrasound guided pleural biopsy, and of course physician-led medical thoracoscopy, which a lot of us now perform as routine practice. So the main clinical practice points that we wanted to summarize in this document were, first of all, to review the evidence, look at patient selection, look at indications and contraindications of pleural procedures, how to troubleshoot, complications and rates, a how-to guide, which was published as an appendix to the clinical statement, look at aspects of peri-procedural care and informed consent, all of which are important, just as important really to the procedure itself. And then there are some other highlights that I just thought I'd mention before we sort of get into the thick of it, included in the clinical statement, which is guidance around sort of pleural fluid diagnostics and sample collection, the optimal speed and method of drainage in therapeutic aspiration, management of re-expansion pulmonary edema and surgical emphysema, management of IPC-related complications, IPCs in patients undergoing systemic chemotherapy with possible neutropenic side effects, IPC use in transudative, non-MPE, and local anesthetic thoracoscopy troubleshooting guidance as well. Okay, so this is a chest X-ray of a 46-year-old patient with really advanced emphysema, cannabis-induced, comes in breathless to an A&E department of a district general hospital at about 10:30 at night. This chest X-ray was seen by a senior emergency department physician who thought that given the appearance of the chest X-ray and the presentation of acute breathlessness and pain in the right chest, that obviously we would, I would like to ask some people to volunteer how they would interpret this chest X-ray, but I think given the nature of the talk and the title, you probably know where I'm going with this. So this was interpreted as a right-sided pneumothorax, and you can see here that the drain is being placed. I don't know if you can see my mouse, but I'll just quickly show you here. This is where the tube is. This is a 12 French drain put in very nicely, it has to be said, sort of in towards the right apex. But the first clue that something has gone wrong here is you can see that there is some surgical emphysema that's starting to develop. And lo and behold, when you get the CT scan, you can see that the drain is actually inside the lung. Now, this is a very, very common occurrence. I would say this is probably one of the most common things that we see happen in terms of pleural procedures, and this was as recent as April 2025. This is another very memorable case, I think, from the last 18 months that sort of came to my attention. This was a lady, a 78-year-old lady, again with advanced COPD, who was seen by a senior respiratory trainee, actually, first thing in the morning, as the nurses alerted her as she came into work, saying that this patient was very, very breathless. The patient, you can see here on the X-ray on the left, that there is some difference between the right and the left, perhaps not very clear. This was interpreted as a pneumothorax. You can see here in the X-ray on the right that the drain is inserted. You can't quite see the where the tip is, but if I show you on the laser pointer, you can see that it looks like this goes in quite advanced into the chest, into the mediastinum, sort of right, almost traversing the midline. So this is really one of those reports that I read, and I thought this is really should be a never report, because it's a report that you never want to read, but also an event that you never want to happen. So this was the clinical history. This was how the request was conducted. So clinical history: chest drain inserted for pneumothorax this morning as patient was in extremis. Post chest X-ray reviewed, query improperly cited, now draining blood, urgent CT thorax to assess position. I need to just dump my laser. So this is how before I show you the images, I just want to show you the report because it was just such a memorable read for me. So comparison made to the previous CT of 14th of January, there is a chest drain which traverses through the pleura and into the pericardium. The drain traverses across the superior aspect of the left ventricle through the superior cardiac recess between the aorta and pulmonary trunk. It is immediately adjacent to the LAD. The tip of this lies adjacent to the SVC. No hemopericardium, remarkably, and there is a large left hydropneumothorax. The left lower lobe has now also completely collapsed, as well as the left upper lobe, so no aerated left lung remains. The right lung is clear. Pneumopericardium with chest drain in the pericardial sac. The referring clinician has been informed. And this is, you can see here on the image on the left, this is the SCOUT. You can see that the drain actually just escapes the diaphragm, goes above and goes straight into the pericardium. And if you look at this image on the right, of course, what's happened, because there's been such displacement of the left pericardium, that it goes straight into, when she's put in the TUI needle to insert the guide wire, she's gone straight into the pericardial sac, and therefore the drain has gone in. And you can see this very scary appearance of the chest drain, which can only be described as kebabbing really the pericardium straight in. And the way it's managed to avoid these two big vessels and not create a catastrophe is rather miraculous, I would say. So these are two simple examples of really how these really common procedures that we perform day in, day out can really be near catastrophic. And I'm sure many of you have many, many examples of these as well. So we recently conducted this review. This was done was when I was in the specialist advisory group, the BTS National Pleural Specialist SAG, and this work was led by my friend and colleague Andrew Stanton, who works in Newcastle, and we wanted to conduct an organizational audit and ask centers all over the country about patient safety incidents that were still occurring related to pleural disease. So this was a wide open survey that went across the pleural leads all across the country. And remarkably, more than 60% of hospitals reported pleural related safety incidents. There were 21 incidents of level 4, which was severe harm in 3 years between 2021 and 2024, 2 deaths directly related to a pleural procedure, 17 cases of direct organ puncture, 13 involving the liver. Only 4 out of 21 incidents documented appropriate ultrasound use, which was really quite fascinating. So these were cases that were assessed by those pleural leads as having required ultrasound use appropriately, so which means basically that they were not necessarily pneumothoraces, and then 90% occurred outside the respiratory settings. And so really the main take home from this was that 15 years following, that very famous MPSA alert that really shook us all, patients are still dying from preventable procedural harm. And you don't find these things unless you go looking for them. And I think that's the sort of the main thing around sort of regular auditing, regular surveying, someone taking responsibility to identify these things within your trust or within your hospital area. Now, I just want to briefly touch on this area of 90% occurring outside respiratory settings. And this isn't really sort of a point and blame exercise, but I do feel that what's happened slightly over the last decade or so is that we have kind of democratized pleural disease as a subspecialty a little bit, where it's a lot of interest from emergency physicians, acute physicians, intensive care physicians, and there's no offense to any of these colleagues who may be on the call, but I do feel that what's happened is that standards have been slightly relaxed. Whereas, for example, if you look at gastroscopy, done by gastroenterology, or and angiography done by cardiologists, this is a very, very strict in-house training where you would only do these procedures if you've had dedicated time in training and fellowships, etc., etc. Whereas we see less of this now, I think, in respiratory medicine, where a lot of front door colleagues, doing very basic sort of POCUS training and things like this are doing pleural procedures. And in my opinion, and it'd be interesting to hear, Gary's and others' comments. I don't necessarily think to the right sort of training standard. So this document was published in November 2020, and this was guidance to support the implementation of local safety standards for invasive pleural procedures, otherwise known as LOCSIPs. These were really, I think, inspired by the airline industry. Some of you may have seen Gary Lee's Twitter ad for this talk, where he shows sort of 2 airplanes near colliding. And the idea is that you want to, whenever you're performing any sort of procedures in hospital, the surgeons have done this for many, many years, is you want to create a standardization of practice. You want to have a consistent, structured safety process that can inform any procedure happening anywhere. And this was really built on the back of the NATSIPs, which were the NHS England national safety standards for invasive procedures, and encourages uniformity across the institutions to reduce variability and risk. So the emphasis on human factors and teamwork as well, focus on communication, situational awareness, and non-technical skills as well. So it promotes clear role assignment, team briefings at the beginning of the procedure, at the end of the procedure, a safety culture where everyone, from the student nurse to the most senior person, is able to stop when they have any concern about any procedure. These are safety checklists that we now use as standard. So these are to be done sort of at the WHO safety checklist. This is done at sign-in when the procedure starts, to check whether everything has been looked at, the right imaging, we've got the right patient, we've checked the bloods, we've got all the equipment and things like this. And we do the sign-out as well at the end of every procedure. This happens regardless of whether procedure is being done, in the resus room in the emergency department, or whether it's being done in the main theatre. The standard should be the same. So if you are doing a pleural procedure, then I urge you to check your rights, and not your right necessarily to do the procedure, but have you got the right patient? Have you got the right procedure? Does this procedure need to be done by you, or do you the right person to do this? Do you have the appropriate training? Do you have someone to get you out of trouble if the procedure goes wrong? Do you have the right supporting staff? Do you have an assistant? Do you have someone who knows knows the procedure well enough to be able to help you if you get out of trouble? And is this the right time to be doing the procedure? Can it be delayed until the daytime if it's out of hours when there's more people around? And is this the best environment to be doing the procedure? And so if for those of you who are racing driver fans, you will be familiar with Alain Prost. It was a famous French racing driver between sort of early 80s and early 90s for Ferrari, famously nicknamed the Professor. And if you remember Prost's surname, if you think of a mnemonic, just to go through these things in your checklist, or you may have a better way of remembering these, but it is a useful six-piece checklist to go through every time you're doing a procedure. Anticoagulation is often a concern, and what we did in the clinical statement is we also covered guidance on what to do with anticoagulation, because this often causes a lot of stress. And the main thing that I wanted to sort of emphasize in this talk was that the bleeding risk of the procedure and patients' individual risk factors for bleeding and thrombosis should be evaluated. So I still come across patients having their chest drain for an empyema delayed for 5 days, while the ticagrelor or the clopidogrel washes out. And I think that is inappropriate, because obviously that patient is then culminating worse and worse sepsis and getting significantly more and more unwell. And this is sort of guidance that was created in association with the British Society for Hematology guidelines, and daily prophylactic heparin should be considered if you are bridging, and obviously that risk should be assessed on an individual basis, depending on what the reason for the indication for the anticoagulation was in the first place. And just in my final couple of minutes, I just want to talk about how, in 2025, we should really be sort of investing in training clinicians, to perform real-time ultrasound. This is not just, a fancy thing that we use just to show, nice videos and clips, but I think something that has really absolutely changed my practice. And once you get good at real-time, it takes a bit of time to invest in learning it at the beginning. But, this here is specifically a pleural biopsy being demonstrated. But I, myself, my fellows, we almost always perform our procedures on the real time, because once you have that skill, it's very difficult not to use it. And it just gives you an additional level of safety and confidence whenever you're performing any procedure, whether it's a diagnostic aspiration, a chest drain insertion, and it's really worth, spending time with Gary Lee, Vin George, Deepan Sivakumar, any of the excellent pleural clinicians who I know in Australia to spend some dedicated time learning these sort of techniques. And because sometimes even when you do have these skills, this is a famous clip of a pleural bleed occurring after a biopsy from Professor Najur Rahman, and accidents still can happen. But if you've done everything you can to perform the procedure in the safest way possible, then at least you've guaranteed that if you go back, there is nothing that you could have been done differently, and there is still some risk even there. This is a technique that we published when I was doing my PhD. This was intercostal vessel screening. Some of you may know Vin George, who is very kindly being my hand model for this paper, demonstrating how the technique is done. This is done using the same curvilinear probe and using color Doppler to fan across the rib space to try and identify the intercostal artery. And particularly when you're doing posterior procedures or small spaces, I think it is very useful technique to perform. It takes literally a matter of seconds. And just to summarize the paper without taking too much time, this is a very simple technique, can be done using the same probe, part of routine practice. None of us who did this for this were formally radiology trained. We were just pleural practitioners who are appropriately trained in ultrasound. And I think it is important to remember that the overall bleeding rate from 8 studies reported pleural procedure-related bleeds at 1.7%. So there is still potential for a safety benefit. And at this 1.7% may seem like nothing, but when you consider how many procedures are done sort of on a daily basis across the country or across your continent, then that is significant indeed. And finally, just to share with you some other highlights from the BTS clinical statement. So there is some guidance around suction and digital drain devices, ambulatory devices, intrapleural therapies as well, such as talc, autologous blood patch, hemolytics, pleural irrigations, and how to guide for LA, local anesthetic for pleural procedures, how to set up a chest drain and an underwater seal, and how to drain an IPC with a vacuum, particularly for some of our specialist nurse and allied health professional colleagues who may be on the call. And there are some patient information leaflets and consent forms that can be adapted within the clinical statement as well. So just to finish up, in the 1 year sort of 2019 to 2020, we conducted 21,700 pleural aspirations in England alone. So even a 1% risk of harm was potentially 216 patients coming to harm. The BTS 2023 clinical statement provides a comprehensive pleural intervention guide. In 2025, ultrasound is no longer recommended, but it is absolutely mandatory. This is reflected in the BTS guidelines. This is reflected in the ERS statements on thoracic ultrasound. And remember your rights, those 6 rights. Adopt LOCSIPs and safety checklists within your practice, and seek appropriate pleural training if you are going to be doing these procedures, and always know your limitations and when to abandon. And thank you for your attention.
Great, thank you, Eihab, and excellent talk. And I think most people who log on today will already be very respectful for the pleural procedures. One of the things that maybe you can share is about training requirement. So what at the moment is your recommended training requirement, and is it compulsory that people have to reach a certain standard before they're allowed to do procedures, etc.?
Yeah, so we are in the late stages of publishing the first BTS pleural procedural training standards document, because I think we've always sort of focused on ultrasound. We had sort of the RCR recommendations for level 1, as you know, and then recently there was a thoracic ultrasound training document published by Andrew Stanton as well, that you may have seen. But pleural procedures were never sort of in their own right given a sort of direct attention, and the way we do things now is that when trainees are coming through, respiratory trainees, they obviously have to do a certain number of procedures under direct supervision, but there is sort of now a move towards, generally in the educational community, towards entrustment and levels of entrustment, and now what is the onus now is on trainees to sort of collect those levels of entrustment, accumulate them as they go through the training, depending on sort of the complexity and the sort of the volume, the range of pleural procedures that they're doing. So I think you can't say that, the numbers, I think, has some limitation. Numbers, I think, are important, because I honestly, and Gary, I don't know what you think, but I don't think there is an alternative to experience. There is nothing better than experience. But obviously, if you come and tell someone that you just need to do 10 aspirations and then off you go, then they could do 10 very simple large volume aspirations, and then you've signed them off, but then the first aspiration they encounter out of hours is more complicated. So it's a combination, I think, of numbers and entrustment, but certainly time as well.
And I think I have to review that for the journal that is going to be publishing, and the surveys that you guys put out for the clinicians to say how many numbers people should do for each of the procedure range from like less than 10 to 200 or something for each of them. And I can't help looking at that and smiling. And it's such a wide range, because there's just no one safe number, is it? So that's
no, 100%. Yeah.
Now, one question online, Lugaski was asking the question, which is probably what I want to ask as well. While there are definitely advantages of doing real time in small effusions or loculated place, quite a lot of us prefers to use 2 hands, and so that we don't always use real time. What's your thought on that?
Two hands, you mean in terms of for the
so
actual?
So that we don't hold a probe. So we ultrasound mapped, but we don't. Because
yeah,
using two hands is somewhat safer to some of us.
Yeah, no, I mean, I think that's fair. I mean, look, I think you have to obviously, adjust the procedure to what you feel comfortable with and what feels safe at the time. I think I'm not necessarily saying that I think every single procedure, needs real time. Ultrasound assistance is adequate in a lot of situations, but I think, we definitely shouldn't be marking at the bedside. We shouldn't be tapping, large effusions. We shouldn't be doing any of those things anymore. So as long as ultrasound is used, real time is something that I just personally find very helpful, and I know that a lot of people who we teach find it as well. But of course, you know what the procedure requires at the individual time.
Yeah. I guess when I used to learn how to drive, my dad said you can't drive unless you learn how to change the car tire or jump start the battery. So it is how, if you're doing a procedure, you should need to know how to manage when things goes wrong.
Yeah.
And that is not always easy, because obviously we don't like to have things goes wrong, and it only happens in maybe 1 out of 100 or 2 out of 100. And so most people who are licensed to practice have never actually managed a real life adverse event. So is there any more those or teaching methods that you would advocate for that?
Yeah, I mean, I think this is part of the problem. I mean, and I think without a doubt, it goes without saying that usually the most dangerous procedures are the ones that happen out of hours when there's less people around. And I think we haven't cracked this in the UK either. I think, we often discuss in the open SAG meetings, I'm sure you've attended some of these, about, what the right model is, whether you have, a plural on-call model in every, region to sort of, come and do urgent procedures whether they're needed, or to be around if there's any problems. I think there should be clear SOPs as a minimum standard within every department as to, if you're, doing a procedure and you run into problems, this is the IR person who can get you out of trouble. This is the thoracic surgeon, if, who can get you out of trouble. These are sort of, the ABCs that you should do, etc. And everyone sort of has that sort of minimum sort of thing that they can reference. But it is difficult, and I don't think it's so difficult to adopt it to sort of every setting and every hospital in a uniform way.
Yeah. Another question online. I'm just trying to read that from here. So, excellent talk. Perhaps also add to the right side to your list is the right patient. Is that too many drains were inserted in the wrong hemithorax? So this is an interesting thing.
Yes. Yeah.
I think with ultrasound that shouldn't usually happen nowadays, I would think. We have seen it, but it's probably unusual. Is that your experience?
Absolutely, yeah. No, I mean that's why I think the WHO safety checklists are so important, because one of those things specifically asks you is, have you reviewed the imaging? Is this, the right? Are we doing, the procedure, the right procedure, the right side, etc., etc. So yeah, completely agree.
You mentioned about intercostal artery screening. So
Yeah.
what do you do when you see it? Or what
So
do you do when you can't see it?
Yeah, no, I think that's a good question. So I didn't want to, obviously, for the interest of time, I didn't want to sort of go too much into detail. But what in around a third of the patients where we did identify it. So usually, if you can't see it, then you're less worried, because it probably means that it's encased with behind the rib. It's probably being hidden. But if it is exposed, then it's probably sort of in the middle and could be potentially within your plane. Obviously, to try and show a direct sort of safety correlation, we would have had to do this in about 10,000 patients, obviously because of the risk. So we weren't adequately powered in that study to show a safety signal, but I think we showed at least that as practitioners, in a third of the patients where you do identify it, it makes you reconsider your location and look either for somewhere slightly lateral or somewhere, one space up, one space down, to adjust your position. And in about 5% of cases, the procedure was completely abandoned, because we just felt that it wasn't safe to do it. Those posterior, I'm sure you'll think think of, those posterior complex empyemas, where you haven't got a lot of room. And sometimes, you have to think, is it actually worth the risk, or, should we just treat this patient with IVs and see how they go? So I think it's a useful tool to have that really takes seconds. So yeah.
Yeah, I think one of the important messages is that the best way to prevent adverse events is not to do unnecessary procedures.
100%. Yeah.
And that's why, I mean, trainees often comes to us and say, I want to do X number of procedure or X procedures. And we often say that the best thing to learn is actually about pleural medicine, so that you be doing all the right things at the right time using the right instruments. Yeah. Okay, so we reached 1:30 and there's no more questions on the chat room. So I'll just take this opportunity and thank Eihab again for getting up early and delivering an excellent talk, and very timely reminding us that pleural disasters do happen, and it is important to take all the safety procedures. Thank you again, Eihab. Thank you.
Pleasure. Thank you, everyone.